Good afternoon, one and all. At the outset, I would like to thank Mexican Academy of Pediatrics and Professor Eduardo for inviting me to this academic feast, and I am humbled for their invitation. And I would be speaking on a very important topic, which is approach to a dysmorphic neonate. In the next 30 to 40 minutes, I will be covering the topic under the following headings. We will discuss what is dysmorphology, how to evaluate a neonate who has dysmorphism, what all investigations we should order for such neonates, what are the various genetic tests which are available with us, and finally, what are the databases which are available with us to make a diagnosis. Dysmorphism is a cause of concern and anxiety for parents. And to bring features of dysmorphism to the notice of parents is the task of treating neonatologist or pediatrician. Sometimes it's quite difficult to convince parents that their child is having dysmorphism because of the subtle nature of the variations. In this time of anxiety, providing a correct and timely diagnosis is a daunting task. Also, remember that these malformations are not uncommon. In fact, major malformations are seen in 2 to 3% of neonates, and minor malformations are even more commoner, to the tune of 10 to 15%. Before we go further, to understand this topic, we need to understand certain definitions. By dysmorphic, we mean that anything which has disordered shape or form. Malformations mean a morphological defect resulting from an abnormal developmental process, and these can be further of two types, that is major malformation or minor malformation. Major malformation is one which interferes with day-to-day activity and requires surgical correction, whereas minor malformations are mostly cosmetic and do not require any treatment. Dysmorphology, on the other hand, is a study and attempt to interpret the pattern of human growth and structural defects. That, in short, it is a study of dysmorphism. Once a neonate or a child has features of dysmorphism, he can be clubbed into one of these three. That is, the malformations can be a part of either syndrome, association, or sequence. We need to understand the difference between these three common terms. A syndrome is a pattern of features with a unifying underlying cause. That is, the cause of all the different malformations or pattern of features is one. Whereas in association, which is there is occurrence of two or more anomalies which occur more frequently than can be explained by chance, but there is no unifying underlying etiology. The common example is vectoral association. Sequence is a pattern of multiple defects which result from a primary malformation. The commonest example being Piri-Robin sequence. The main primary malformation in Piri-Robin sequence is a small jaw. Since the jaw is small, the tongue falls backwards, which is known as glottosis. As the tongue falls backwards during the fetal period, the palatine process which are developing at the same time, they are unable to fuse, leading to cleft palate. Therefore, we see that how one primary malformation leads to second and then one after the other. This is known as sequence. Now, for all these malformations, there are underlying etiological mechanisms, and they can be one of these three. That is, it can be either because of deformation, disruption, or dysplasia. Let's understand these terms better with the help of this diagram. Deformation, as you can see in this diagram to the right, it's a defect in normally formed structure due to a mechanical pressure. That is, the tissue was normal to start with, but because of the mechanical pressure, it resulted in its abnormal shape. For example, clubfoot, which can happen because of the overcrowding of the uterus, as can be seen in multiple gestations. Whereas in disruption, a tissue has started forming normally, but because of some external agent, the tissue gets distracted. The commonest example being amniotic band sequence, where the limb buds start developing normally, but because of the amniotic band, directly or because of the interruption of blood supply, because of the amniotic band, it leads to destruction of the limbs. On the other hand, dysplasia is an abnormal organization of cells into the tissue. That is, the process is abnormal to begin with. Most often, dysplasia is tissue specific rather than organ specific. For example, skeletal dysplasia. Now, why do we need to understand the etiological mechanisms? It is because majority of the malformations, because of the deformation, they are spontaneously corrected, or whatever is left behind can be treated surgically, and there is hardly any risk of recurrence. Same is true for disruption, that there is no risk of recurrence, whereas in dysplasia there is high risk of recurrence and there is no treatment, that is, it cannot be corrected. Now what we have learned so far is that congenital malformations can be because of the various mechanisms, which includes deformation, disruption, or dysplasia. They can either be clubbed into a syndrome, association, or sequence, depending on the clinical features. And the causes for majority of the congenital anomalies includes either a teratogenic exposure, for example, exposure to teratogenic drugs, especially in the first 3 months of life, like warfarin, vitamin A, intrauterine infection, maternal diabetes, or it can be because of a chromosomal disorder like Down syndrome, Turner syndrome, or these malformations can result from a single gene disorder like Apert syndrome, and sometimes the cause can be more than one, leading to multifactorial etiology. Now, to diagnose dysmorphism, we need to have eagle eyes. That is, the clinician should be able to pick even subtle signs of dysmorphism. So once we suspect a neonate with dysmorphism, we should take a thorough history and do a detailed clinical examination from head to toe. Then, depending on the positive points in the history and clinical examination, we should order first line investigations. And once we are having results of these investigations, then depending on clinical evaluation and investigations, we should make differential diagnosis. Sometimes, in order to reach a diagnosis, we have to do certain genetic tests for confirmation. And then, depending on the disease, we have to intervene and prevent or treat complications. Most of these neonates and children lead long-term follow-up for growth monitoring and for treating and preventing various complications like endocrine disorders, complications related to sexuality, and finally, we have to offer genetic counseling to these parents. Now, just like any disorder, history taking is most important. History taking can be broadly divided into three parts, that is, family history, antenatal and natal history, and postnatal history. Here, I provide a checklist which has to be kept in mind while taking a detailed history for such patients. These includes maternal age. Maternal age more than 35 has been associated with increased risk of chromosomal disorders. In fact, paternal age also has been associated with certain disorders like Angelman syndrome, achondroplasia. Any history of fever and rash, especially in the first trimester, is a strong pointer towards intrauterine infections. A clear history of teratogenic drug or any toxin like alcohol can be a direct cause of embryopathy or teratogenicity. And the common drugs which cause these malformations are warfarin, valproate used for seizures, vitamin A used for acne. Remember that history of repeated miscarriages, especially in the first trimester, can be a pointer towards balanced translocation in one of the parents. Also, the technique of conception, that is whether it is a natural conception or because of a result of assisted reproductive technique, needs to be known. This is because assisted reproductive techniques increase the risk of malformation by almost 2 times, and also certain forms of ART like ICSI, that is intracytoplasmic sperm injection, have been associated with disorders like Bequeth-Riemann syndrome, Russell-Server syndrome, and Angelman syndrome. Moving further, we need to ask about history of maternal diabetes, because diabetes itself is associated with embryopathy. As the levels of sugar go up, or as the HbA1c levels go high up, the risk of embryopathy increases. If there are antenatal investigations like serum markers and ultrasound available, they can make diagnosis easy and early. Amniotic fluid abnormalities like oligohydramnios and polyhydramnios are an important marker of various malformations. We all know that fetal urine is an important contributor of amniotic fluid, especially in the second half of pregnancy. Therefore, any genetic genitourinary abnormalities can be associated with oligohydramnios. Similarly, polyhydramnios may be because of the difficulty in swallowing of the amniotic fluid by the fetus, and it can be because of the neuromuscular or GI malformations. One should not forget to take a detailed family history, such as consanguinity, ethnic background, because some of the facial features can be normal for a certain ethnicity, and also various disorders are common in some ethnic groups compared to others. Also, we need to know about sudden deaths, sudden sibling death, or deaths because of jaundice in siblings. These are important markers for inborn errors of metabolism. And whenever we are taking a family history, it is important to make a 3 generation pedigree chart. Moving further, in the postnatal period, we need to know the gestational age, because some of the features can be normal for prematurity, such as some degree of clitoromegaly in a preterm female neonate, whereas the same is not true for a term female baby. Similarly, an unformed air cartilage is quite common in premature babies, but same can be an important marker of dysmorphism in a term neonate. We also need to know the resuscitation details at birth, because in order to differentiate between encephalopathy because of asphyxia and other causes. A detailed family history is also important get a clue about the mode of inheritance. For example, consanguinity increases the risk of autosomal recessive disorders. If there is a vertical transmission, especially male to male, then it is an important pointer towards autosomal dominant disorders. And if only males are affected, then one can think of X-linked recessive disorders. However, if there is history of two similar affected siblings but of different gender, then one can think of mitochondrial pattern of inheritance. For examination, one needs to do a detailed head to toe examination, and the examination is incomplete at begin with anthropometry. One needs to plot weight, height, circumference, and length on gestational specific charts. Remember that if we do not use gestational specific charts, we may erroneously label a normal baby as abnormal and vice versa. And the examination should begin with head and neck, because face is the index of dysmorphology. Majority of the times we get a clue from examining the facial features itself. Some of the important features which we should look is the head size, ear and eye shape, their position. We also need to look for various digital abnormalities, palmar creases. Similarly, whatever system is affected has to be examined in detail. One should not forget to examine skin, because uneasy skin pigmentation increases the risk of involvement of the central nervous system because both are ectodermal in origin. These two diagrams show various details of face and oral cavity which have to be taken into consideration. For example, the length of the philtrum, the vermilion border of the lip, the mentolabial sulcus, all should be looked into carefully. Similarly, examination is incomplete without examining the mouth. For cleft lip, cleft palate, the tongue should be examined for any fasciculations or abnormality of shape. One also has to examine genitalia in detail. Also examine all limbs and musculoskeletal system whenever we feel there is involvement of any bone or we suspect skeletal dysplasia. Although no diagnosis can be made without a complete detailed examination, but there are few diseases which have characteristics features and these should be kept in mind. For example, we have pursed up lips in whistling face syndrome, we have broad thumbs in Rubinstein tabby. Similarly, if there are radial ray defects, one can think of Holt-Oram syndrome, TAR syndrome. Absent clavicles are important markers of cleidocranial dystocia. Heterochromia iridis is again a marker of Waardenburg syndrome. Similarly, we all know that webbing of neck is common in Turner and Noonan syndrome. And if there is hyperextensibility of skin and joints, one can think of connective tissue disorder like Ehlers-Danlos. Here we see the broad thumb, which is typical of Rubinstein-Tabby syndrome. Similarly, as discussed, that mitten hands are typical of Apert syndrome. Moving further, I would like to re-emphasize never to forget examining spine for any skeletal deformities like kyphosis, scoliosis, and any lipoma, dimple, or a tuft of hair. These can be important markers of underlying spinal dysraphism. Similarly, one should not miss any opportunity to examine genitalia during routine examination. The genitalia should be looked carefully and one should examine whether the testes have descended, rugosity of the scrotum, the position of the anus, anal opening, and for any anal tags. The common measurements which we do is interpupillary distance. For that, we can use this simple formula where interpupillary distance is outer canthal distance minus inner canthal distance into 2 plus inner canthal distance. Similarly, for labeling ears as low set ears, we need to draw a horizontal line from external canthus of the eye. If the air is below this line, then it is known as low set ears. Normally, one third of the air is above this line. For workup, we need to plan according to the history and examination. If we suspect involvement of the skeletal system, then we should do a detailed skeletal survey and infantogram. It is good to do neurosonogram, 2D code ultrasound abdomen of babies with dysmorphism because these are non-invasive and can reveal important examination findings. If on investigations we found involvement of the brain, then we can do second line investigations like MRI brain. Also, this is important for a baby who has features suggestive of CNS involvement like seizures and cephalopathy. Metabolic workup should be done when we suspect inborn risk of metabolism. For example, in a child with a sibling death because of inborn risk of metabolism, or because of a typical order, or sudden worsening after introduction of feeds. And in majority of these babies, genetic test is important either to make diagnosis or to confirm a diagnosis. In genetic workup, we have karyotype, FISH, microarray, and clinical exome available with us. Coming to the karyotype, it is the most common genetic test which has to be done. And the indications for doing karyotype is whenever there are multiple malformations or a major malformation, there is a growth deficit or a developmental delay, or there is a failure to develop secondary sexual characteristics or ambiguous genitalia. However, certain points need to be remembered that a normal chromosome analysis does not exclude single gene mutation or micro deletion syndromes. This is because The karyotype resolution is not able to pick defects which are less than 5 MB. Similarly, normal antenatal chromosome analysis does not completely exclude chromosomal abnormality, especially if the phenotype is suggestive of one. This is because in the antenatal sample obtained from amniotic fluid or coronary venous sampling, the resolution of chromosomal banding may not be adequate. Therefore, a postnatal sample should be done in any baby where we suspect a chromosomal disorder based on clinical examination, even though his antenatal genetic test may be normal. Quite often, we are asked when to do a genetic or karyotype after transfusion. Although the possibility is rare that during testing we may pick up a we may pick up a donor lymphocyte, and the test may turn out to be false normal. Therefore, it is a good practice to wait for 7 days after transfusion before sending a karyotype for a neonate. The other technique which is commonly used is fluorescence in situ hybridization. This In this technique, we use a fluorescent labeled specific DNA sequence based on the disorder which we need to detect or diagnose. Then the same is hybridized with the patient DNA to detect presence, absence, abnormal number, or location of any fluorescence signal with the help of special scanner. Now, when should we order fish? We should order fish whenever the phenotype is suggestive of a specific microdeletion or duplication syndrome, for example, DiGeorge, Angelman, William, or Miller-Diecker syndrome. The resolution of fish is much more than the normal karyotype, and it ranges from 100 kb to 1 MB. In this diagram, we can see that a standard probe for chromosome 22 shows two green spots, whereas when we apply a specific DiGeorge region sequence, we can see that there is only one red spot indicating the deletion of the same for the other chromosome, suggesting DiGeorge syndrome. Coming to the next test, which is microarray test, it is of two types. The array CGH compares patient genome against the reference genome. It mainly detects copy number variants which are defined as 1,000 or more base present in variable numbers of copies in comparison to the standard DNA. We should order microarray study whenever there are multiple malformations with or without associated intellectual disability and without any other identified genetic or non-genetic cause. Remember that microarray scans the entire genome for copy number variations, and it is a good test to detect micro deletions and duplications. We can understand it better with the help of this diagram. The sample DNA is color coded with green, whereas the reference normal DNA is color coded with green. They are then hybrid, and in order to detect the exact location of the abnormality, it is broken into multiple fragments and put into array. If there is no deletion or duplication, then there will be equal amount of green and red color giving a yellow circle. Whereas if there is addition, there will be more green color giving rise to the green color. If there is deletion, that is less of green, there will be more of red. Therefore, those spots will feature as red. They are then, once the abnormality is detected, they are then mapped to particular chromosome to get the exact location of the abnormality. Coming to the other type of microarray, which is SNP or single nucleotide polymorphism array, it detects the most frequent type of variation in the genome, but however, majority of these variations are non-pathological. The advantage with this technique is that it determines both the copper number variants as well as loss of the genetic material, that is loss of heterozygosity. It is also good to detect aneuploidies like triploidies. Now, when should we offer microarray as a first line test? Whenever there are unexplained learning difficulties, there is intellectual disability or cognitive impairment, there is developmental delay, behavior problems like autism spectrum disorder, or there is dysmorphism, miscarriages, or there are abnormal prenatal tests like ultrasound. This figure gives a summary of the various genetic tests which we have already discussed. What we have not discussed is clinical exome, which is a good genetic test which screens all the introns for any abnormality. However, if there is abnormality in the non-coding region, that is intron, it will not pick it up. It is a good test to detect monogenic disorders, skeletal dysplasias, and inborns of metabolism. However, its cost and availability are its major limiting factors. Now, when should we do a metabolic workup? Remember that dysmorphism, which is because of the metabolic disorder or because of the inborns of metabolism, is progressive. That is, the dysmorphism will worsen with the age. Also, these children often have cataract, cloudy cornea, there is regression of milestones, there is peculiar odor, there is resistant seizures, organomegaly, encephalopathy, and often there is sudden worsening after starting feeds. Some of the inborns of metabolism which are associated with dysmorphism include mucopolysaccharidosis, which have coarse facies, organomegaly, and cloudy cornea. We have paroxysmal disorder like Zellweger syndrome, which presents with hearing loss, hypotonia, seizures, visual impairment. And in this disorder, there is increase in the very long chain fatty acids. Similarly, we have a disorder of cholesterol metabolism known as Smith-Lemli-Optay syndrome, which presents with microcephaly, growth retardation, subnormal intelligence, and abnormal developmental of gonads in males. And it is associated with low fasting serum cholesterol and high 7-dehydrocholesterol. Now, it is important to make a diagnosis because it helps us in predicting the complications and giving appropriate management. Also, it allays the anxiety of the parents. The diagnosis can be based on either the pattern recognition, that is the experience of the clinician itself, or we can search various databases which are available with us. For searching a database, we need to select various features. Remember not to select more than 3 to 5 features, and only the rare features should be selected. Remember that rarer clinical features or rarer investigation abnormalities gives the most accurate diagnosis. Some of the databases which are available with us are London Dysmorphology Database, which is a paid site. Similarly, there is another site known as POSUM, which is again a paid. Both these sites give good details and pictures of these syndromes. Then there are some other websites or databases which are free. For example, Online Mendelian Inheritance in Man, also known as OMIM. And then we have a book which gives quite exhaustive description of the malformations and syndrome known as Smith cognizable pattern of human malformations. In the present era of apps and gadgets, now we also have an app available both on the Android and the Apple, that is Face to Gene. This app, in this app, we have to feed the photographs of the patient and some clinical details, and it has got a good positive rate of around 70 to 90%. Here in this picture, we can see that one of the cases diagnosed with Face to Gene app. It's very easy, and the positive result is described as if the actual diagnosis comes in the top 10 list. Remember that once we feed the photographs and the clinical details, the most likely diagnosis is displayed serially. That is, the most likely diagnosis will be numbered 1, and less likely diagnosis will follow it. That is second, 3, 4, 5, 6, and so on. Now, because we see so many features of dysmorphism, now there are databases based on the phenotype which are free and easily accessible. The most important or most useful I have listed here. The definitions can be easily obtained from this website, which is again free. If we have to know details about a particular disease or a syndrome, then we can go to this omim.org, and in order to get a diagnosis, we have to feed features in this website, which is again free, and we can get the diagnosis. Now, when should we admit? We should admit whenever a unit has major malformations because it can be life threatening. It is good to admit neonates with two or more malformations because they are often associated with the underlying syndrome, and because of the trivial nature of the malformations, the follow-up of these patients is poor, and if they turn up, it's already too late. Similarly, any patient who is unstable, for example, any patient with respiratory distress and encephalopathy, symptomatic in the form of seizures, is not feeding well, or requires surgery, they need to be admitted. Now, can we prevent dysmorphism? Yes, to some extent we can prevent, especially if we are using ART, that is assisted reproductive technique. We can make a prenatal diagnosis or pre-implantation genetic diagnosis. Mothers who have diabetes or hypertension should be asked to make a strict control of their blood sugar, and HbA1c's level should be tried to be maintained in normal levels. Same is true for hypertension. One should avoid teratogenic drugs and toxins like alcohol, in especially in the first trimester, and whenever there are infective diseases based on the region where we live, we should the female children should receive adequate vaccination. The treatment depends on the presentation, type of malformation, and the cause. However, majority of the conditions do not have a specific treatment, and treatment is largely supportive. Surgeries available for various major malformations like congenital heart diseases. One should also not forget to get a detailed eye examination and hearing assessment done in these babies as early as possible so as to prevent or treat any hearing or visual impairment. Genetic counseling is an important part of management for such neonates. A follow-up is required to assess the growth and development, also to detect any endocrine abnormalities. It's also important to anticipate or treat complications, and what is not available today may be available tomorrow. So these patients should be available, and whenever any new treatment comes, it can be offered to these patients. Remember that sometimes the phenotype evolves with age, like Noonan syndrome or dysmorphism related to inborns of metabolism. Therefore, reassessment at a later age may lead to diagnosis of these children. As discussed, that genetic counseling is an important part of the management. It is important to communicate concerns to the family. It's also important to be gentle, not use harsh terms. Also, one should provide detailed mention of all the malformations and show it to parents, explain them the severity and prognosis of the condition. One should also explain it to the patients that the malformation is not because of the parents' fault and they should not feel guilty. It is good to counsel these patients and parents with your colleagues which are involved in the management of these babies. For example, neonatologist, pediatrician, pediatric surgeon, genetist, and other elite branches, depending on presentation and organ involved. My take home messages are that one should avoid spot diagnosis because no diagnosis is better than a wrong diagnosis. One should never forget to examine spine and genitalia of these neonates. Before labeling a neonate as dysmorphic, one should always have a look at parents. For example, look at their head size and facial features. And remember that sometimes it is not easy to make a diagnosis at birth. Therefore, one should follow up these patients, and some phenotypes evolve with age, and then it may become possible to make a diagnosis. If there is any malformation, one should always screen the neonate to rule out other malformations, especially if the child is undergoing a corrective surgery. Thank you and have a good day. Remember to check these websites for definitions, diagnosis, and disease conditions. I again thank the organizers for providing this opportunity. Thank you.